Welcome everybody to the InnovAiT podcast first live stream session. And in this one, we're going to be kicking off with an absolute bang. We're honoured to be joined by one of our RCA examiners, a gentleman talking about 14 fish, and one of the own AIT network colleagues, basically helping us to direct some of these questions and basically answer the questions that you have about the RCA exam. I'm Dr. Gandhi. Let's get started, shall we? Hello everybody, and as I said, we're talking in this live stream about the RCA exam with that little slant point about the InnovAiT podcast and basically how we can try and help you answer those questions you've got for the RCA. We've got some really distinguished guests with us, and we're going to be talking about all the questions you've already submitted. I'm more than happy to take some that you're putting in the live stream, so feel free to add your questions. We'll try and get through as many as we can. Couple of disclaimers just to mention. So we will try our best to answer what we can, but there's maybe some questions that we can't answer, and we'll be honest and open about that throughout the stream. So firstly, if I can go to Sally to introduce herself as our RCA examiner.
Hi, I'm Sally Hemmons. I'm a GP in Edinburgh and a trainer, and I've been an examiner for quite a long time, and I'm on the RCA core group.
Thank you. Next, I'm going to go to Jonathan, who's talking from his library by the looks of it.
Yeah. Hi everyone, I'm Jonathan. I'm a GP trainer. I'm also an RCA examiner. I'm on the RCA core group, and I also am a PD and AD and have the role of the clinical lead for the portfolio at the college.
Awesome. And finally, Mira, want to say hi?
Hello everyone. I certainly don't have a list of impressive things like that. I'm an ST3 trainee who has yet to take the RCA, so really interested to listen to everybody's questions and get some of my own answered as well.
Awesome. And for those of you that don't know me, I'm Dr. Zain Gandhi. More of you probably know me as Dr. Gandalf. I do a variety of different hats, but for this one, I'm here as the podcast editor, and we're going to be talking basically about the RCA and trying to answer your questions. So I guess I'm going to go the first one to Sally, if that's all right. And it's, I guess, a really important question that kind of sets the tone for everything else that we're doing today. What is the RCA?
So the RCA is a remote assessment of consulting skills. It's an assessment of a doctor's ability to integrate and apply clinical, professional, communication and practical skills where appropriate. And it's designed to be sat in ST3 or beyond. In fact, you're not allowed to sit it until you're in ST3.
Cool. So I'm going to ask all of our viewers that are watching and enjoying this right now, if you are thinking of sitting the RCA in the next few months, then give us a thumbs up in the comments, and that lets us know how many of you are thinking about looking at this exam in the imminent future. So yeah, Mira's thumbs up and stuff, but yeah, if you are in the chat, let us know. That'd be awesome. So next question I'm going to ask. So we've heard about what the RCA is, but recently there have been a couple of changes, and this was a question that we have had. And what exactly are the changes to the RCA? Do you mind talking us through that?
Yeah, so the RCA was designed as an emergency assessment last year in the middle of COVID, and then has been refined and developed over the last year, really. So there was the introduction of some mandatory criteria, which are laid out on the website, and then those have just been changed slightly. So there's some new changes at the top of the website. When you look at above what the RCA is on the college website, it lists them. So clinical examination, for example, will no longer be mandatory. You used to have 2 cases at least that involved clinical examination, and that's no longer a mandatory requirement. And there is a clarification on breast lumps do not count as a mandatory under the mandatory criteria of reproductive and maternity health unless they relate to the postnatal period. Those are the main recent changes. It has evolved, as I said, the mandatory criteria came in back in the autumn last year. Jonathan, what have I missed?
12 minutes, that's probably the biggest one. So initially, from the start, it was 10 minutes. And the reason for that was because that's what the CSA was. And when we brought this in, we were obviously having to comply with GMC, but this was all done very quickly, and it had to be equivalent to the CSA. Therefore, we couldn't suddenly at that point make the consults longer than 10 minutes, despite us maybe wanting to, because that didn't reflect general practice at the time. we've now had enough time and have gathered enough evidence that we can put this to the GMC to say, actually, general practice has changed, we do need more time, and that's where the 12 minutes has come in. So that would be a big change.
Cool. And I think with that change, so that definitely relates to our next question that we've had. So is gaining consent considered part of the 12 minutes? I don't know if probably your best to answer that, Jonathan.
Yeah, absolutely. So no, it's not. So if you're using the 14 fish system, a lot of the time the 14 fish system will arrange consent, but some trainees also just double down on that consent as part of the recording. But what I would say is the examiners know that the timer doesn't start until that consent is obtained, should that have been recorded. So when we're actually examining, we have a big timer clock on the screen as well as the consult, and we won't press start until that consent has been obtained.
This is a really common query actually to the exam department, and that's why it's in the FAQs as well, because people get very worried about it actually. So, and they often touch base to say, hi, I'm so and so, and is that okay? That is out with the 12 minutes.
And I think there's definitely a lot of my ST3 colleagues are trying to practice recording consultations before they sign up to the 14 Fish platform. And I know as part of that, you're obviously having to do the consent process, but it is intrinsically built into the platform and it makes our lives a lot easier. So I think that's one good thing about being able to do it via 14 Fish.
Cool. So next question that we had submitted, a little bit of a complicated one, but let's go through it. So how much emphasis should the trainee apply to past medical history and drug history, for example, given it's on the records? And in some patients, obviously, this can be quite extensive. Sally?
So this is difficult, isn't it? Because you've got a lot of information in front of you. The examiner only has what you're recording, so they can only mark what they put in front of you. One of the feedback statements you'll see, if you look under data gathering, talks about gaining new information. So there's very little to be gained by going over absolutely everything. But you also, when you watch your consult back, need to think, has the examiner got enough information to know that I already knew something that might be pertinent here? And so, but it needs to just follow naturally as it would in your consultation. You know, we often say to a patient, I see in my records X, is that still the case? I mean, that would be entirely appropriate. But recapping an entire history would not be appropriate because you haven't got time in 12 minutes anyway to do that. And it's where the question of how much to put in is difficult. Some people write when they submit on 14 Fish, there's a little explanation bar, but that is not part of the assessment process. We are assessing the recording that you submit. Does that help? Mira probably is the best person to know if that's clear.
Yes, no, I think that definitely does help. And obviously we're coming on to a question about the dreaded complexity. And I think when you're picking your patients, depending on what their past medical history is, I guess it's how relevant is it to that consultation that you're doing at the time. And it's I suppose the way that I'm looking at it is that the consultations that we're submitting are the ones that in real life, they're as true to life as a real consultation would be. So whether someone has a history from 20 years ago that's irrelevant, actually not that important to include, and being discerning about what you are going to include so that it means that you can cover all the other domains that are expected in a consultation. And I guess that comes with experience and practice as well. Preparing, I guess, is key.
Absolutely. And Mira mentioned the question about complexity. So we're going to tackle that one now. So this is probably the most requested question in various different forms that we've had. But how do you judge complexity when it comes to cases that are submitted for the RCA? I don't know who wants to take that one, but good luck with it.
Well, I said I would start with it. So what we've said is there's actually, I think some people have said there isn't very much. There's actually quite a lot. We have really worked hard to put a lot of information about this on the website. So if you go to the website and look under preparing for the RCA, there is a document which says guidance for educators. So it's called Top Tips to Help Your Trainee Prepare for the RCA and Educator's Guide. And if you scroll down through that, number 17 is all about complicating factors. And there's a lovely box that talks about high challenge, and if there's multiple factors and high clinical challenge, then that box is probably not a good case to put into the RCA, because you're probably not going to be able to do it in 12 minutes. You know, an elderly lady with multiple different complaints whose daughter's going on holiday tomorrow and has got a new medical problem is probably going to be much too complicated. And then on the bottom box of that, it talks about low level of challenge consultation, very limited opportunity. And the problem with that is that you're submitting a recording of yourself for an examiner to make a judgment in 3 domains. So if the problem is very simplistic, even if you've asked all the right questions for it, it may not allow you to demonstrate skills in all 3 domains. So data gathering, management, and interpersonal skills, empowering your patient, because there just isn't enough that is required to be done. And if you think of those domains as having 3 marks each to them, if that you do a brilliant history, but actually the management is so simple. I don't know, for example, earwax. You know, I'm a bit deaf, you've got wax in your ears, you need it syringing. That is actually quite a simple consultation, even if you've talked about how it's impacted on their life. In that document on top tips, there's another link to another document that talks about cases that have been considered insufficient evidence, and it actually lists a lot of areas that have come up that have been not good consultations for demonstrating, and so much more commonly represented in those are dermatology and ENT cases seem to figure quite a lot in that. Now that was at the very beginning of the RCA, when people were first getting used to it, and since issuing this guidance, people have got much more the hang of it. So that's happening much less now, I think. So there are quite a lot of links, but if you click on them, there's lots of information there about how to work out if it's complex enough. So you don't want it to be too complex and not too simplistic. Does that help, Mira?
Yes, no, that definitely helps. And I think it's also important to mention that the website, the links there have changed recently. So there is a lot of information on there that I think a few months ago probably wasn't there. So I know that obviously you may be speaking to ST3s or people who have already CCT'd, who sat the exam and may have had issues with that exam at the time, but things have evolved over time. As Jonathan and Sally have said, they've taken lots of considerations into account with the core group changing some of the elements of the RCA. So there is quite a lot of information on there, which frankly, up until about a week ago, I didn't really appreciate. So yeah, it's important to check that out for sure.
And just to help everybody that is watching, so when this stream finishes, I will try and find those links and put them up in the description of the YouTube video. And for those of you that are listening to the podcast, which is going to be edited and published hopefully tomorrow, it'll also be in the show notes for that as well, so you can access them directly. So hopefully that will make accessing all of this a lot easier for all of you. I'm going to stick with the theme of complexity, and it's a more specific part of it. So a common question we had is, when does mental health consultations become too complex / not complex enough? Now, I know this is possibly covered already, but I know with mental health consultations, it can be a lot more challenging to judge where you're at with it. Particularly, that's been my experience with some of the trainees I've had to get through the RCA as well. So I'd be keen to know how that differs, if it does or not at all.
I think probably with mental health, it's important to say that we're trying to assess the trainee's ability to take a history and come up with diagnosis and management. And so if the patient already has a significant mental health diagnosis, it is already being managed by the GP historically, or is under the psychiatrist, having a review with the patient and just talking about tweaking some medication is not, whilst the case itself is complex, the consultation that we're observing is not complex, because they're really just reviewing stuff that's already been sort of done historically. So it's difficult, because it's probably the hardest one that trainees have found to get into the 10 minutes is the mental health cases. But I would suggest new cases of mental health conditions are more appropriate, because then you're going to get the full history and the diagnosis and the management from that stage. And I think it's just important to try and, base it at a level that a qualified GP would be managing. It doesn't need to be any more complicated than that. So, we regularly deal with anxiety and depression. So along those lines, it doesn't need to be anything more than that.
So if I could extend that slightly, you talked about new diagnoses being fairly good content in terms of, the complexity level we're looking at. How about consultations where you're reviewing a patient following an earlier consultation, but where you're changing the treatment in particular for that patient? Would that, do you feel, have enough in terms of the likelihood of it ticking the boxes?
I suppose the follow-on from Jonathan is that, if we go back to what we talked about as data gathering and management, then your data gathering opportunity is going to be much less, because they've got an established diagnosis, and you will know. It kind of links to the other question about your past medical history, doesn't it? It's much easier to do it on a new diagnosis than a follow-up consultation, even if you're going to change the medication, because you're coming to it fresh, and it's real and it's live, and you're not trying to create an RCA scenario from a patient that's coming in. You are dealing with the patient in real time, in real life, and those just are much more effective, really. So getting your team to triage you, a new case of a mental health problem is a really nice way of doing that. Just having a video surgery and just, bouncing an email out to everyone in the surgery and saying, I'm looking for mental health cases, please give me some. You maybe don't want to do too many whole days of just mental health cases, but actually, trying to get them and getting your team on side to signpost new patients rather than follow up patients is a good way of doing it.
What I would add, though, is now we are seeing a lot of patients who have a history of depression but have had it for many, many years, and have maybe on sertraline 50 or a low dose antidepressant, and having a significant exacerbation of that mental health condition, or a relapse, and I think that is perfectly justifiable, and from that you would still get a decent history and a decent sort of diagnosis and management if it's a sort of relapse. So just because someone's got a history of depression in the past on their notes doesn't mean you can't ever use a case of depression for that patient. You just need to make sure that in the consultation you're asking the same questions you would as a GP to ascertain the history and management.
I think what I'm hearing is, effectively, when we're looking at cases, we're not reinventing the wheel. Obviously, we'll see lots of things that people may have presented with before, but essentially the case needs to be on its own as a unit that you can look with fresh eyes, as if you're taking a history, putting in the appropriate plan. So remembering that those key domains are what we're entirely going to be judged on. So if we can't feel the meat of the bone, so to speak, then it's probably not complex enough. Or if there's too much meat on the other side, then we're not going to be able to complete it. That's sort of what I'm getting from both of you, I think, on that.
Yeah, I think that's right, Mira. And I think the odd case that is a bit longer is okay. But if you've got 13 cases that you're not quite completing, then you're going to run into trouble, because you're never going to get to safety netting and the other things. So I know that, when I've had registrars doing it, there's the odd case that you're not looking for perfection when you pick your 13 cases. You're looking for good enough, really. And I think that is occupying a lot of people, to say, I didn't ask one small question, and remembering that it's not a tick box exercise, it's a holistic picture of it is really helpful, I think.
Okay, so we've had quite a few comments in the chat, and I'm going to try and summarize them rather than bring each one on individually, just because they're all very similar themes, if that's all right. And Jonathan's already answered the question that came through about relapses in case of depression, so thank you for that. But a lot of them seem to theme around the concept of chronic conditions with patients, but they have potentially an exacerbation or a flare of that chronic condition. From what I've heard from what you said so far, that should be okay to use, as long as that exacerbation or flare in itself has information that you're getting from the patient and managing on the basis, yes, they've got a background of a chronic condition, but you're still managing that flare episode. Have I got that right?
Yes, and they would obviously be suitable cases for one of the other mandatory criteria, which is about chronic conditions.
Yeah, awesome, cool. So we've had, I think we've covered most of the other, in brief, we've covered the other questions, but we'll come back to them if not, that we've had from the chat. But I will carry on with the ones that we've got for now. So let's move away from complexity, because I think we've covered that. Fingers crossed. So something a little bit more practical. Tips to handle clinical management if we're converting a face-to-face for examination before starting treatment. I know when I had trainees, this was something that caused a lot of confusion as to how much they go into. So really would appreciate, clarity, I guess. Jonathan?
Yeah, can you just bring the question back up again?
Oh, of course, sorry,
so I can get my head,
so
yeah.
Tips to handle clinical management if you're converting to a face-to-face for examination, but before starting treatment, because obviously you may not be, well, the recording won't show the face-to-face examination, will it?
No, so therein lies the issue, because we can only mark what we see. So what I suppose we don't want is trainees to guess what the examination might be and therefore come up with a sort of a treatment based on what they think they might find. So it's very difficult, and it might be that this is not the best case to use because it doesn't demonstrate all three sort of areas of the assessment. Now we've got rid of examination, I think that's helpful because a lot of trainees are spending a lot of time describing what examination they will do when the patient comes in, and hopefully we won't, have all of that. I think it's a difficult question because there's no right answer, but if Sally's might have a better suggestion.
I will. So I was a fielding doctor, so did a lot of this, and actually to get a patient to come in, you quite often could link your management. I want you to come in because I think you might have, I think this is what you've got, but I want to make sure you haven't got a chest infection. I want someone to do your obs and make sure you haven't got a chest infection. I think it's this, in which case you're likely to have, I don't know, a water tablet, or if there's signs of a chest infection, they would give you an antibiotic. But I think that we need to do that before we see you. I think that does tie in your management. I think what Jonathan says is you have to be aware that the amount of management you might be able to share and empowerment you might do with that patient might be limited by that. And I think someone asked earlier about how much information do you have to give about the examination. And I think it's the same amount of information that you'd give to a patient normally. You don't do anything different for the RCA. If I want a patient to set foot inside the surgery and I don't know, they're an elderly lady, I've got to have a good reason for doing that. And I will explain to them why I'm bringing them in and what my differentials are. So I am doing that, all of that comes into management. So I think you would do what you would normally do with a patient, but it can add an added complexity, and it takes time that takes away from the time of the management.
No, I think that's very helpful, because I think on one hand, when I read the updated, you don't need to do a clinical examination, but of course, whenever we're consulting somebody, 50% of the time they may need to come in for something at some point. And I think a lot of people had asked me as well, saying, are they expecting a running commentary, much like you would in medical school OSCEs, of I will then check your eyes? And I thought, well, no examiner wants to listen to what you're going to do. It's just, we'll be doing a neurological exam just in case X, Y, and Z. And if it's this, we'll be doing this. And if it's that, we'll be doing that. And I think that reassured me a lot, because I really didn't fancy doing a running commentary for all these examinations. So that's really helpful. And I think you shouldn't be shying away from submitting consultations where you will need to examine someone, as long as they meet all the other criteria. I think that's reasonable.
Yeah, and I think if you look on the mandatory criteria bit, clinical examination does sit there still in that table under recommended rather than mandatory, because actually including some cases with examination is good, because it helps you demonstrate your skills, but you don't have to do it.
I think the other thing to add is there's nothing stopping you doing a sort of a triage, a fairly basic triage, and bringing the patient in and actually recording the face-to-face part rather than saying, when you come in, we'll do this, this, and this. You could actually take a bit of a history. When the patient comes in, as we often do in practice, you go, really, thank you for coming in. You know, we spoke on the phone earlier. What you said to me then was you've got this, 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 and this, and then take it from there. So just briefly recap the sort of the short triage you may have done on the phone, but record the face-to-face. That's another option.
And definitely a tip I give to my trainees when we're doing triage clinics and explaining how they work and run and stuff, and definitely hear a lot of the things I've been saying today in practice, actually. So yeah, cool, good to know. So next question we've got, will the feedback to trainees improve beyond generic statements which aren't linked to specific cases? I know feedback comes up a lot in commentary and stuff. Love to know your thoughts on this, Sally, and then Jonathan.
We're going to do
Well, shall I go first?
I think.
Yeah,
Jonathan's
I'm going to go first.
Okay, fair enough.
Okay, so when we were designing the RCA, we obviously, it's so important to think about feedback, but ultimately this is a formative assessment. And so there isn't, unfortunately, the time or the funds to have a lot of time for the examiners to give summative feedback on the cases. So it is limited in what they can do in the RCA. The reason to give the feedback in themes rather than case specific is because these cases are not standardized. So knowing that you did one case slightly badly in that particular case with that patient doesn't mean that if you saw that same case again that you would do that case particularly badly. So because the cases aren't standardized, knowing that you did one particular case wrong doesn't generally help. And we have a lot of trainees that completely fail one case but still pass. So what we're really looking for is themes and ways that you can improve your consultations for every consultation, not just one consultation that you did badly. So knowing you did one consultation, you did this wrong, doesn't really help. But knowing that as a whole, you do poorly on interpersonal skills or you run out of time, that's actually something that you can work on with your trainer. So the feedback statements have been improved when the RCA came in. So when they came in, they were from the CSA. Then we improved them to try and make them more specific. There's a lot of guidance on there if you look at it. And the frequency that these statements come up is obviously the more they come up, the higher to the top they are. And if you look at the information there, it does give you a lot of information of what you can do to try and improve on that particular area. And I think it's just important to stress that the feedback statements at the bottom do not feed into the results. They are completely separate. So the examiner marks the assessment and then can give some feedback statements afterwards to help guide the trainee improve their practice. But unfortunately, there isn't a lot of time to sort of spend more time giving free text answers. Hope that explains that.
Sally, you're on mute.
The other bit, I suppose, of that is, I mean, that's come up a lot, and there's been dialogue with the AIT reps about this a lot, that to get individual feedback would add time to the day and would add a cost. But obviously, ultimately, we don't want to increase the cost, which is why we've developed all these documents under feedback, where you can look at each feedback statement and it gives you general guidance. Which is just the same as the CSA. People used to get that guidance, and trainers are good at utilising that and saying, and sometimes the registrars knew themselves that there was a particular area that they, had been working on or needed to work a bit more on. Okay,
so next question, if that's all right, sticking on marking and that kind of stuff. Is there a specific mark scheme for each condition? Or is it the subjective mark scheme with the descriptors available on the RCGP website?
So I'll go first on this one, shall I? So no, there is not a specific mark scheme for every condition, because, I mean, every consultation doesn't just involve a condition, it involves the patient and the situation. And so you couldn't possibly have one that was generic to that. All the examiners are or have been recently active working GPs, so we all are used to general practice consultations. So it is marked using the generic feedback statements, which you can see on the website for each domain. And then you get a flavour of what we're looking for by looking at the feedback statements that you get of things that might be missing from those things, which are expanded on there.
Okay. Jonathan, was there anything you wanted to add?
No, nothing to add to that.
Cool. All righty. So next one, sticking on kind of themes and that kind of stuff. So what are the common themes for those who fail the RCA, either individual cases and globally?
So certainly at the beginning, it was the low complexity cases were the biggest issue. So and as Sally had sort of said, they were mainly ENT and dermatology cases. So simple skin things, simple earache, earwax. I think that has changed slightly because the trainees are sort of doing cases which are more complex. A lot of it has been time management and just running out of time, and therefore compressing the consultation. So missing out on important things as a consequence. And I think that again has helped sort of lead to the change and making it 12 minutes. But there are certain, if you look on the RCGP website, there are certain things which come up again and again, and reasons why. It's not a particular area and it's not particular conditions, but there are some themes that we see which we documented on the RCGP website.
And I suppose under preparing for the RCA, again, there is an old document, which is an analysis of passing and failing candidates in the CSA. But actually, a lot of that is still relevant. So it talks about different domains, data gathering, what a good candidate looks like. It gives you a summary of that and what sometimes causes an issue. And that's still relevant because it's basically about consulting skills and how that applies. And I agree with Jonathan, time management can be a bit of an issue, but I know I had a registrar who sat at 10 minutes and said, actually, that really, she said, I see they've changed it to 12 minutes, but actually I learned lots about my consulting skills to make them more succinct by getting to 10 minutes. So there are lots of things that you can do in your consulting skills to help you with that your trainer would guide you with. I mean, all sorts of techniques.
I've just thought of one other thing. It's that we see a lot. It's where the trainee has a very sort of fixed consultation style, and they often have potentially got it written down in front of them, and it's really obvious that they're not necessarily listening to the patient, and so the patient will say stuff and they miss it, or they don't sort of pick up on some of those cues. So that's something we see a lot as well.
Absolutely agree. I think one of the challenges is with trainees is understanding that concept of active listening. So obviously when you ask a question, listen to the answer, because often they give you the next three ones that you want to ask already, and not then asking straight away, or how long has it been going on for? Oh, it's been going on for 3 days and it's been moving into my arm. Oh, where did it move to? And yeah, I can definitely understand that, because it's active listening. It's a tricky skill to learn initially, but once you've got it, it makes life so much easier with consultations.
And I think there's a lot to be said about practicing recordings before you're obviously picking ones to submit, because I think I'd never really heard myself back or how I would consult ever before, and I only started doing it in the last couple of weeks, and actually there's some things that I did that I'd never realized I was doing at all. So I'm really glad that I've recognized that now, so that I know when I'm going to start recording for the exam, I can think, okay, these are the things I need to be mindful of, as opposed to being really stressed later in the line when I've got to pick some consultations and I'm not happy with any of them. So I think undoubtedly, as you say, perfection is probably not the goal. It's, is this good enough? Am I safe? Am I covering the domains? So yeah, that's.
And Mira, we'd certainly advocate that you just have routine video surgeries from the very beginning, SP1 and SP3, so that actually you can just switch off and just be yourself. The more you're yourself and interested in the patient in front of you, the more we see of you, the better, usually. And when you're interested and interactive with a patient, and because it's real, because you're just doing your normal consulting, the better that is for you and for the patient. So that when we see you forming a partnership with them, not thinking, oh, the examiner's watching this. It's like that extra head, isn't it, that from Roger Neighbour, you've got another head. Oh, am I saying the right thing to the examiner? If you can forget that and just focus on your patient, because you've been doing it since the word dot as a GP, then that's much better.
Thank you, everyone. So we've only got a few more questions left. I'm going to ask a couple more, and then we're going to go to the ones that we've got in the comments and finish off with the last two, if that's all right. This is still a similar theme, but I guess a bit more complicated. Is there anything that's being done to address the differential attainment in the RCA? I don't know who wants to take that one.
I'm happy to start. So I think the most important thing to stress about differential attainment is there is a new area on the RCGP website which directly addresses this and gives some information. Obviously, we're aware of the differential attainment. It existed in the CSA, and we obviously had hoped that going to the RCA that would reduce the differential attainment, and it has. Not as much as we had perceived it may do, because we thought getting real patients would close it even more, but it has improved the differential attainment, which is contrary to what maybe some of the rumours and some of the other sort of organisations have been saying. It is something we're conscious of, and again, we've thought about how we can try and reduce it further, and that's again another reason why the 12 minutes have come in. And it's certainly something that we continue to look at, but we're probably never going to be able to completely get rid of it. But as long as we continue to address it and think about what we can do, I think that's important, and we are doing that. But I think it is important, if you're interested, to look at the college website, which has recently added the new paper looking at that. The reason that it's taken a long time is because you really need enough data to be able to make any conclusions with any of this stuff. And actually, if we'd just done that, a few months in, the data would have been so small, it would have been really difficult to compare it to the CSA or the AKT. We now have 12 months of data, and that's what's been produced on the college website.
Thank you, Jonathan. It's interesting. I've said similar comments when it was talking about the vaccinations for the 12 to 15-year-olds on the radio earlier today. So yeah, it's amazing how much data helps to make those decisions and the actions that come from those decisions so much easier, because you've got more information to make a more informed decision. Next one we've got is, are telephone consultations valued differently to video consultations? Sally?
The short answer is no.
Okay.
They're all exactly the same. I suppose one theme that comes up quite often in the 14 fish questions is, can I submit an audio of a face-to-face consultation? And the answer is yes, but it's probably not a good idea, because you're only getting half of the information that actually is going on in the consultation, because the examiner can only hear the audio, but there's visual cues there. If you submit either a video where you're both on video, or a telephone consultation, that's fine, but you're on a level playing field. And so if we can see and hear what you are seeing and hearing at the time, that is helpful. And a lot of consults are telephone consultations or video consultations, but some are face-to-face. I saw in the chat someone's put about PPE, does that get in the way? Well, in as much as it gets in the way for any of us, you've got more interaction than you have on the telephone, because you've got your eyes and everything else. And we certainly aren't judging on PPE, because of course the rules are changing all the time, and in different areas they're different too. But yeah, so I wouldn't say that wearing PPE hampers your face-to-face any more than it, but I mean, because we've all got used to it. We've been doing it for 18 months really. And
I think that's important to stress, is that all the examiners are either still GPs actively working and wearing PPE ourselves, or have recently retired, but are well aware that PPE is not a choice, and so they have to take the context of the assessment based in the fact that it's being done via, during a pandemic. But we were seeing some face-to-face where PPE was being used and some where it wasn't, obviously dependent on particular areas. And the people that are doing it without PPE don't score higher just because, you know, they're not having to wear PPE. It's done on the relationship with the patient.
And I think that's really important to hear it from you guys. I think undoubtedly there are lots of myths going around. You hear lots of things from people who've done the exam before that say, oh, if you only submit telephone consultations, you won't pass, or if you only do this or you only do that. But actually, as you have rightly said, they are all weighted exactly the same. So if that works for you and you're going to submit 13 cases that are all telephone consultations, as long as, again, going back to hitting those domains, then it doesn't matter if you don't have any face-to-face. So that's really reassuring to hear that from the examiners' mouths.
And I think that answers one of the questions we had in the chat from Nami, talking about, would you recommend a mix of audio and video / face-to-face consultation, or is all audio okay? Pretty sure we've answered that question, but yeah, seems okay and stuff. One little tip I'm going to give, if you are looking at doing, obviously, the video recordings for face-to-face consultations, as Mira mentioned, do a practice run and check for the audio. So even though I know some people have concerns about PPE and masks covering it, making sure that when you start recording, you've actually done a dummy run with the device you're planning to stream with, really important. And if you are concerned the audio is a bit of an issue, a simple little shotgun mic that you can get to stick into your phone or whatever you're using to record with, worst case, they're about 15 quid. I'm sure the practice will be more than happy to support you with that, and it will significantly improve the audio. Many of you probably know I love my gadgets and stuff, and that's a quick and simple way of basically taking some of the stress away from you in terms of getting the audio right. Then you don't at least have to deal with that question. Cool.
That's really helpful, because the exam department get questions about, my audio wasn't quite clear. Will the examiner be able to, if I write in the bit? I think if you're in doubt as to whether you can hear it, then you probably should look for another case. Because if you're not quite sure, then it's a shame to use it, I think. So I think someone asked something similar about, they've got something on their screen that their trainer thinks might be a breach of exposure of an intimate area. I think if your trainer thinks it might be a breach, then it's not worth the risk, really. As annoying as that might be, then I think you have to be, I think if there's any question about it, then you probably shouldn't include it.
Sure. So Ibel asked the question, I have a consultation where pictures of babies with erythema toxicum was open on my secondary computer screen. It's not so clear and it's even zooming in. My trainer thinks it may be a breach of exposure. I guess one of the things I would mention that in terms of, obviously with us doing more photo and video type consultations, intimate areas of under 16s is an absolute no-no. If there's any form of visual elements of that, shouldn't even be doing that in practice, to be honest. And if you are, I'd be asking you to look at the way that you're practicing. That's with my digital hat on, to be honest. But yeah, I agree that images need to be, I think if your trainer's saying, I'm not sure, it's probably worth listening to it.
Yeah.
Well, I think it's worth listening, because otherwise you're going to have sleepless nights thinking, oh, I wonder if I'm going to get a thing back from the college saying I breached. It's not worth that extra stress, I would think, to you. Over to Jonathan.
I was just going to say that although that image might be from a website which is published and already sort of available for everyone, the examiner doesn't necessarily know that. And, it's going to potentially flag up some concerns, and you just don't want to be going there. So any uncertainty, I would not use it.
Cool. I've lost the next question. Where's it gone? Here we are. Save. There we go. So how do we standardize the case in context of NICE guidelines? I'm guessing this is more focusing on management. But yeah, any tips or tricks for us to be aware of in terms of managing the cases?
I mean, what I would say is, again, this is an assessment of real life. And so we're not expecting perfection. We're not expecting, someone to necessarily follow the NICE guidelines rigidly. These aren't standardized cases. But what I would say is, if you are seeing a patient and you're talking about what we're going to do next and the management, and you happen to have the NICE guidelines up on the screen, like I might do in real life, and you say, look, the guidelines suggest that the next thing we should do is this, that's absolutely fine, because that's real life, isn't it? That's real life practice. So you can use resources. This is essentially an open book assessment. And in real life, if you're using these resources, then utilize them. But don't not submit a case just because you later read the nice guidelines and it says you should have done exactly, this, and you didn't quite do that, if what you did is what everyone, other GPs would do.
And I suppose the addendum to that is that NICE is English, and this is a 4 nations exam. So as I'm sitting here in Edinburgh at the moment, we have sign guidance, and there are differences between sign and NICE guidance, and we all have local variation in guidance as well. I think if you say, I'm going to get you I'm going to get you physiotherapy because that's the next thing to do on our guidance, and you can have that next week, then I think we all know that wherever you are in the country, that's probably unlikely to happen, whether you're wherever you are. So I think guidelines are guidelines, and they are there to help us. But often we, for different reasons that we usually share with the patients, we may not exactly follow them. But for the majority, we often will. But there will be local variations when they're in all sorts of protocols and guidance that we have, from, I don't know, chest pain clinics to everything else. There's not a standard one size fits everything, really. If you're way outside and doing something that isn't clinically acceptable generally, then you may be wondering about whether that's a good one to submit.
Yeah, definitely. I was just coming in on the local variation thing that both of you touched on, because obviously guidance is changing all the time, predominantly because of the pandemic. Hospitals are having different rules, and you are trying to keep up with what's allowed to be referred in or not. But also even with blood tests at the moment because of the national tube shortage. So when recording cases, it's I'm assuming, and I think you will agree with me, it's in the context of the time that we are in at the moment. So as much as PPE is acceptable because we're here, if you're not able to do a specific thing, as long as you're explaining that to the patient and saying, we can't do this, but XYZ, then I think that that's perfectly acceptable.
Absolutely agree. And I'm reminded by what Sally said about a comment from David Haslam. So he's the former president and also former chair of the RCGP. He also, I believe, had a position in NICE, and he classically said at one of the RCGP conferences that guidelines are guidelines, they're not tram lines. So, you don't need to stick to them like you're literally going down the tube tunnel and stuff, as long as you explain what you're doing, that's the key thing. We have loads of questions in the chat, and we have 10 minutes left. And I've got 2 questions that we are going to ask to the panel that have been pre-submitted. But I'm going to cover just a couple of the ones that we've got in the chat briefly, so we can get to some of these cool things. So Narendra asked the question, would you explain about red flags and safety netting if a patient is coming for a face-to-face examination?
I think you can only safety net and red flag based on the fact that you're going to bring them in. So, if anything's happening, it depends when you bring them in. So if you're going to bring them in later that day, it's very difficult to say, oh, and in 2 weeks, you develop this, then you need to call us back, because you're going to see them fairly sort of quickly. If it's, go on, Sally.
That's all right. It was one of the other. It's been one of the other changes that we didn't talk about at the beginning, that we were seeing a lot of not appropriate safety netting, and it wasn't realistic. So, I'll see you this afternoon, but if X happens, dial 999. So I think it has to be in the context, as Jonathan said, when it's going to be. So if you are doing a face-to-face in a week because you haven't got any appointments, then you would obviously need to put in a proviso for if things changed. If it's this afternoon, then it needs to be realistic safety netting. The same as if, if you're on a duty day and you say, I'll see you this afternoon, but if things worsen, give me a call back, then that's realistic. So it should be realistic and appropriate to the consultation and on the history that you've got already.
And I think this just emphasizes the point that you don't have to hit every single component of each area to pass the assessment. So if it's not appropriate to do that, then that's fine. And if I'm getting a patient down to see me, in a few hours, I suppose that is the safety netting. I'm getting them in. So don't start saying, oh, and if this happens, and if this happens, if this happens, because that's not appropriate what you would be doing.
So we've got one more specifically about examiners themselves. So how many examiners assess each cases? Are all the cases assessed by the same examiner or by different examiners?
So each case is there are, of your 13 cases, they're all examined by different examiners. So and they are examined by at least one examiner, and currently it has been by 2 examiners for each case.
Okay, nice and clear. So any tips for how to manage time in face-to-face consultations, especially the examination part of it, as it makes it impossible for me to finish up in 10 minutes, especially for maternity and reproductive cases / elderly?
So this is a common area that comes up in how do I save time, and it was one of the good things about the CSA. It was a good study group activity for all registrars, was to practice examination. So you have a selective choice of your examination from your history, and you practice it on each other. So people got really, really good and really slick at doing quick knee examinations. So it's an area just to practice, to be quicker, and you're not doing. We were chatting earlier about you're not doing a medical student full examination. You're doing a selective. It's the examination you choose based on your history to confirm or refute the diagnosis. So it's about practicing that. And I noticed they said in 10 minutes, so you've now got a bonus 2 minutes because it's now 12 minutes that you've got. It was me who forgot at the beginning.
And I would say, sometimes it is unrealistic to get a case down to 10 minutes. So they talked about maternity. So if you're doing a full antenatal assessment of a lady, you can't do that. If you're going to be examining the fundus, measuring, that isn't possible, in which case I don't think that's the right case to choose.
Cool. Right, a couple more questions. So I think this is one that's probably going to be on a lot of the trainees that are probably just starting in ST3. Any ideas what's next after the RCA?
Good question. So there is a group that's formed that is already looking at this. It's not going to be the CSA. So the CSA no longer really is assessing general practice as it is at the moment, and probably how it's going to be in the future, because it was all face-to-face. I think it probably will be some kind of mixture of RCA type CSA, but more likely bringing back in some standardized cases, because that will improve the ability to give feedback to trainees. And that's been a request from the AITs, throughout this process is they would like more feedback. And the only way to do that is to have standardized cases, really. So I think that's probably the direction it'll go, but this is all being looked at the moment. Time wise, obviously when this RCA came in, we had a very, very short period of time to bring this out, and that allowed us to bypass a lot of the normal checks from the GMC. Although they obviously did look at it all in great detail, we had to model the CSA. This is an opportunity for us to really radicalize and change and make it as possible assessment. So it will take time, and likely we're looking at 2023, because once you have researched, developed, piloted, then submitted to GMC, it all takes an awfully long time. So I would realistically thinking it's going to be 2023 before it comes in.
And I think the trainees have verifiably been reliably been told that if there is going to be a change in the exam, then the college will be informing people, giving them enough notice. So there will be a 6-month notice period, grace period before that will happen. So if you are in ST3 now and you're not planning on taking time out or whatever else that may be, then you are going to be sitting the RCA this year. It's not going to be changing anytime this year.
Yeah, and just to say that we also have AITs on the group, that's developing these assessments. They've been involved all the time. We have lay members, and the people that are developing these are experts in education, but also RGPs. I think it's just important to emphasize that.
Okay, so final question that we've got for this evening. It's probably going to be the most important one for those that are just about to sit the exam. Oh, wrong one. There we go. Top tips for passing first time round. As I'm going to be a little bit more specific, what are your 3 top tips that you would give to trainees who are sitting the exam first time round? Jonathan, you want to go first?
Well, the first one I would say is just be yourself. So act like this is a normal case. So we want the RCA to assess real life practice rather than the practice to be decided or changed by the assessment itself. So I encourage my trainees to just treat it as a normal consultation and just see as many patients as you can. You know, the more you see, the more patients you see, the more you practice, the slicker you'll become, the better the GP you become, and the more you can get in. And I think the other thing I'd probably say is something that Sally mentioned is practicing examination skills. It is something that in the CSA trainees used to meet every week. Well, I certainly did when I took the CSA, and we would meet up and we would just go through cases and we would really nail the examinations and just get them so slick. And I think we've certainly, I've noticed as a TPD, we've lost that in the RCA, and the trainees are not getting together to revise and they're not practicing their examinations. And I think that whilst there aren't that many face-to-face consults that we're seeing on the RCA, I think trainees would feel more confident at submitting those cases if they felt more confident with the examinations. So that's my tips.
Sally?
Jonathan's pinched mine, obviously, which is consult, all right? See real patients, do out of hours, do phone consults. It's absolutely the best preparation, way and above anything else that you can do. Much better than going on lots of courses, because sometimes courses are just confusing. I think doing your work-based placed assessment stuff is also good preparation. So doing COTS and using the Bradford grid so that you can see if you're covering all areas is also a good way of seeing. We talked about videoing, so just do videoing from the word go so that your reception team are slick at doing the consent bit for you. It doesn't get in the way. And I'm going to add another one is just be yourself, be interested in this patient. Why is this patient here now? And how can I share and improve their journey? So about empowering patients and listening to them. And I suppose that the sort of proviso to all that is please don't let it take over your whole life, because actually that just causes you huge stress. So making sure you have a balance in your life is really helpful, I think.
Can I just add one more comment? Sorry. When the RCA came in, the trainees had 3 weeks to produce the consults for the assessment. And subsequent to that, they've had up to 6 months. And the pass mark hasn't got any higher just because the trainees have had more time. All it's done is added stress and slightly changed the way that trainees are consulting in practice. So again, really emphasis is on learning to be a GP, and then towards the end, recording those and submitting real consults.
I guess I'd echo that. So having had 3 trainees go through the RCA in the space of a 2-month period, in one sitting and then 2 going through the second sitting, almost every single case they ended up submitting were cases that they actually had in the final week and a half. I think partly that's the standard exam pressure. You need to have something. Partly understanding that it doesn't have to be perfect, it just has to be good enough. And partly because that's when they realized they were actually consulting in the way that they would normally consult. And they got so tired of doing it the exam way, they're just like, I don't care anymore, I'm going to do what I normally do. And actually that was when the content and the way that they consulted got so much better. I guess my personal tips I'd always give, make sure you've got a really good microphone, whether it's a headset for your telephone consultations, whether it's a microphone for your camera that you're recording with, because as much as the video side is really important, the audio is the thing. And if the examiner can't hear it, you're going to struggle. We had challenges with that with my trainees when they started. I couldn't hear what they were doing on the recordings. I'm like, well, if I can't hear it, the examiner's not going to hear it. You're not going to get anything. Fix the audio is absolutely the big one. and get the practice on board with the whole process. Explain what you're doing. It takes a bit of effort, and sometimes you may have to talk to people about how this is working, why it's different. But once you've done that, life will be so much easier. That's, again, something we did in practice. My trainees basically sat down with the reception team and went through everything they needed to do. And after that, so much easier getting cases. And it was just because they didn't know what they had to do. Simple as that. Mira, can I go to you to pick up what you think has been the valuable parts from this session?
All of it. It's been, it's allayed a lot of my fears in terms of, actually, a lot of the information is on the website. That's one thing. So taking the time, instead of thinking, RCA, what am I going to do? Stress and think, I don't really know where to go. I guess it's one, having the time to read exactly what's expected so that the information isn't new to you every time you're submitting a case and someone says, oh, your clinical supervisor says, I don't think this is a good enough. And when they explain to you, oh, I didn't realize I had to do that. So I think one is preparation. The second thing is the thing that I've started doing already, which I hated doing 3 weeks ago, which is recording everything that I'm doing. And certainly there has, even over the last 3 weeks, there's been a noticeable improvement, just because I'm more used to the concept of hitting record and not worrying about that red flashing button and just doing the consultation. So I think there's that. And I think taking your points, Dr. Gandhi, very seriously about a good microphone. I think that's obviously really key to a good consultation. The one about not stressing, I think that's easier said than done when you're on this side of the exam and not on the other side. But absolutely having a well-balanced sort of lifestyle. It's only going to get tougher. There's maybe another pandemic coming along. There are lots of other things going on in people's lives as well. And this is just one part of it. So no, lots of food for thought. And I've really sort of enjoyed listening to some of this stuff. It's going to hopefully give everyone some good luck in their long stay for the RCA coming up.
Absolutely. And at this point, I'd like to thank all of our guests for joining us for this particular stream. I know I've learned loads, and that's saying something, considering I thought I knew all of this and I clearly didn't. So that's nice. And absolutely thank you for giving your time to share your knowledge with all of our trainees. Thank you for the trainees that joined us live and watching this. You are more than welcome to catch the recording again. So this is live on YouTube, and you can get just basically the same link and you'll be able to watch it. If you want to listen to it, as I said, this will be on the InnovAiT podcast, which you can subscribe to and listen to all the other amazing content that we've got that enhances the way that you have the InnovAiT journal and absolutely everything else that the RCGP is trying to pump out and deliver to you to help enhance your training and everything else. Thank you, Jonathan, for your time. Thank you, Sally, for your time. Thank you, Mira, for your time. Everyone that's been joining us, thank you for your time. And as always, we're going to be here to try and enhance your training experience. And hopefully we'll catch you next time as well. See you later.